Last week in Edinburgh, we had the international paediatric IBD community in town for the PIBD meeting held at the Edinburgh International Conference Centre. I gave a few talks there. The first one I want to share with you is on environmental triggers in inflammatory bowel disease, or the exposome in IBD. And this was from a session where I was joined by others talking about the microbiome, the genome, and also talking about the immune system. So here is my talk in that context on the exposome in inflammatory bowel disease. Here are my disclosures. So the gut is central to many aspects of human health and disease. We see the gut mediate environmental triggers that then cause a downstream response in the microbiome, in the immune system, and from there we see many healthy and disruptive processes that can lead to diseases such as Crohn's disease and ulcerative colitis. These are conditions characterized by chronic bowel inflammation with dysregulated mucosal immune response, an altered microbiome, a dysbiotic microbiome, and where there are key environmental and genetic drivers. These are chronic conditions, so they relapse and remit over time. They're highly unpredictable. Unfortunately, for many patients, the progression over time necessitates the need not only for long-term medical therapy or maintenance therapy, but also has complications such as hospitalization, surgery, formation of stoma, for example. There are many unanswered questions still in IBD, and indeed we have a large unmet need. That unmet need in inflammatory bowel disease can be distilled into 10 key points, which I will cover in detail later. But for now, we need to think about how do these diseases develop? Why do people get inflammatory bowel disease? Because if we can understand that, then we can start to think about what we can do to prevent the diseases from happening and from preventing disease flare and disease progression in people who already have Crohn's disease and ulcerative colitis. So the environment is many-fold. It's many things. It's what we eat. It's the environment around us, so pollutants, for example. It's the additives in our food, but it's many other things. It's antibiotics, it's hygiene, it's smoking, it's where we live, it's how we interact with what's going on around us. And so you can see many of those things depicted here. And I'm going to talk about quite a few of these things later on when we come to talk about Crohn's disease and ulcerative colitis. So who gets IBD and why? Well, it was described in ancient times, but the first modern descriptions go back 150 years ago. 100 years ago, descriptions of Crohn's disease, and subsequently distincting from ulcerative colitis. And then in more recent years, we've seen this rapid evolution of the epidemiology of IBD across the world. So in the first half of the 20th century, it was really not very common, including in the Western world, but you start to see in post-war Europe and across North America this increase in the incidence of inflammatory bowel disease. And then more recently, in the recently developing world, you see in particular South America, in the Indian subcontinent, in the Middle and the Far East, this rising incidence of inflammatory bowel disease. And we are moving towards a state where IBD will be very prevalent in most, if not all, of the world. Gil Kaplan has described these 4 phases of the evolution of the epidemiology of IBD. So here in the United Kingdom, in Europe and North America, we're in this 3rd phase, this compounding prevalence phase, where incidence levels have actually stabilized. But because we diagnose people young, because there is thankfully no excess mortality from inflammatory bowel disease, the prevalence, the number of people living with the disease is increasing. Whereas in many other parts of the world, South America, in Asia, for example, we see this acceleration in incidence. And then in further parts, again, for example, Sub-Saharan Africa, we're just in this emergence phase where incidence is starting to be documented. Gareth Jones in Edinburgh has documented our epidemiology very robustly with our Lothian IBD registry, where as of the middle of 2018, we confirmed there were 1 in 125 people living with Crohn's disease or ulcerative colitis in Edinburgh. That gave us a prevalence of 0.78%. Most of these people are being diagnosed in young adulthood, in teenage years, in their 20s and 30s, but noting that IBD can and does occur at any age of life, from very early onset in just a few months of age, right up into octogenarians, as you can see here. The compounding prevalence we've described very nicely. So whilst we were 4 years ago at 0.78%, we're now well on our way to hitting a prevalence of 1%. So that's 1 in 100 people by 2028. And this mirrors what Gil Kaplan and Stephanie Coward showed in Canada and has been shown in other regions now as well. So what's going on? What has changed? Because we didn't really see much IBD in ancient times, and we really don't see IBD by and large in our closest living relatives, our primate cousins. With exceptions, of course. There is the cotton-top tamarin that develops colitis in when it's held in captivity, but not when it's out in the wild. And indeed, that's been used as a model to study what happens with IBD over time. Well, our environment has definitely changed, and this chart from our World in Data illustrates how we've shifted from a very rural population going back to 1960 here across the world to the majority of the world's population living in or moving into an urban environment. That comes along with development of different technologies. You can see here, this is from the USA going back over 150 years. And I've just highlighted a few of these things here. Flushing toilets, running water, refrigeration, power, air conditioning, for example. And this is just a few of some of the more dramatic environmental shifts that have happened in just about 150 years. Within this context, the hygiene hypothesis has been posited to be an explanation as to why we have this increase in immune-mediated diseases. So that's type 1 diabetes, multiple sclerosis, asthma, Crohn's disease, and ulcerative colitis, for example, in association with a decrease in infective illness, thanks to great advances in modern medicine, antibiotics, better medical care, and of course, vaccination as well. Antibiotic use is much more prevalent than it ever used to be, including in early life, and that may give us some clues as to what's going on. And it does appear that very early onset antibiotic exposure may in part contribute in some susceptible individuals to an environment that is conducive to the development of inflammatory bowel disease later in life. Sanitation is something that remains very unequal across the world. It's something that we take for granted in the West now. But in fact, if you look here at sanitation facilities across the world as of 2020, you can see tragically a significant part of the world where open defecation remains very prevalent. So very unequal sanitation across the world, representing and mirroring to some extent what's happening with the instance of inflammatory bowel disease as well. So let's think about this in the context of Crohn's disease and ulcerative colitis. We have genetically susceptible people, which I'll talk about separately another day. We have the microbiome, which we see as being disordered, this dysbiotic microbiome. And then these environmental drivers that are probably mediating through the microbiome in genetically susceptible individuals indeed. So gene discovery has been phenomenally successful, and we'll talk about that soon, as well as the microbiome, where we are understanding more and more, but we're still struggling a bit with the issue of causality here. How much of the observed dysbiosis in Crohn's disease and ulcerative colitis is associated with the development of IBD, the drugs that people take, the inflammation that's present, and how much of it is actually there as a causative factor. We don't really understand that yet. So let's think in a bit more detail about the environment and the environment as it implies to inflammatory bowel disease. And let's cut straight to a new publication this year from the International Organization for IBD in Lancet Gastrohepatology. And this was designed to be practical and helpful based on what we currently know. And indeed, listed are a series of recommendations for people living with Crohn's disease and ulcerative colitis about environmental behaviors that are considered desirable or modifiable at least some of the time. So to avoid smoking cigarettes, this seems like good, healthy advice anyway. We know that smoking is associated with increased risk of Crohn's disease. We know that people who smoke with Crohn's disease do worse over time. Adopting diets that have been proven to work best in clinical trials. This is very sound advice, of course. We have a relatively poor understanding from clinical trials of which diets work best, but we'll come to a bit of that later on. Light consumption of alcohol does not appear to make IBD worse. Of course, there are many reasons to limit alcohol consumption for general health. Depression and anxiety may make IBD worse. This is a big and important topic that Joe will cover later. Incorporating regular physical activity into the routine. Not much direct evidence for this with IBD, but again, very helpful general advice, and I think associated with better quality of life where it's possible. Maintaining normal body weight and muscle mass, and trying to avoid obesity, particularly because it can reduce the effectiveness of drugs. We saw that in the PANTS cohort, where it's associated with increased immunogenicity to anti-TNFs. And certainly, obesity can increase the risks of complications post-operatively. It seems very sensible to avoid regular use of high doses of non-steroidals. We used to have a slightly more blanket ban on non-steroidals in IBD. Intermittent use of standard doses of non-steroidals is probably okay, but there will be some variation for individuals here too. But what about if you have IBD already and thinking about having children? This is one of the big questions we often get asked. The first thing to note is that even if you already have inflammatory bowel disease, it is very unlikely that your child will develop Crohn's disease or ulcerative colitis. It does run more strongly in some families than others, and many people with IBD will come to us to ask these questions. We don't have hard and fast answers here, but again, we have some sensible bits of advice, I think, to encourage breastfeeding where possible, to avoid unnecessary antibiotics in early life, and this is probably in the first few years. Clearly, antibiotics are life-saving in some situations in early life, so that you should never withhold them for where there's a good reason to use them, but to avoid unnecessary antibiotics seems sensible, and avoiding secondhand cigarette smoke as well. A couple of things I'll come to. Consider having dogs as pets. Yep, we'll look at that. And also limiting consumption of processed and ultra-processed foods, I think, is sensible. This is a recently published epidemiological study from Scotland, from David Wilson and his team, looking at a very large number of children, 2 million children, and their records born between 1981 and 2017 across Scotland, 1,700 incident cases of pediatric onset inflammatory bowel disease in this cohort. You can see the median age of first admission of 12 there. And then looking at the factors that were associated with development of IBD. And interestingly here, feeding type was not associated with development of pediatric onset IBD. So this was slightly going against the grain in what we had thought in terms of breastfeeding being protective. But of course, it wasn't detrimental, and there are many other good, well-established benefits from breastfeeding where it's possible. What about this issue about having dogs as pets? Well, this comes from one of the publications from the GEM study presented at the Digestive Diseases Week meeting in San Diego in May this year, where a lower risk of Crohn's disease was identified in children growing up with a dog when the child was between the ages of 2 and 4 years of age. A large family size over 3 individuals in the first year of life was also noted to be protective. A couple of interesting extra findings. Dog ownership correlated with abnormal gut permeability, and that was when the child was between 2 and 4 years of age. Other ages that wasn't seen, and there was no link found between dog ownership and calprotectin or microbiome composition and diversity. So there's a few unanswered questions here yet. And of course, there are many other really great quality of life reasons for having a dog in childhood, or indeed at any stage of life. So what about diet? Let's have a think about diet in a little bit more detail. This is self-reported dietary choices of Brits from just a few months ago, at the end of 2021. And I think it's interesting, this is self-reported, so it doesn't actually give us any robust data on what people are actually eating, but you can see the separation by age. You can see the number of people that now consider themselves to be flexitarian, the number that consider themselves to be vegan or vegetarian or meat eaters. I think it's worth just bearing in mind, because when we think about dietary studies, there are a number of different ways we can collect the data. And in particular, when we think about the impact of the diet and the microbiome, which is one of the things that we're really interested in IBD. And in this chart, what you can see here is what happens when you plot out shifts in the microbiome throughout lifetime, looking at the different impact of different eating. For example, from breastfeeding to weaning to solid foods, this period of healthy diet in the middle and reduced food diversity in older age at the right. But I perhaps just point your attention to this 24-hour window in adulthood, where you can see, even with normal healthy diet, these shifts in what's happening in the microbiome over relatively short time windows. And if you look at some of the data that we have, this is a publication from Nature from 2013, where a group of healthy people were given a plant-based diet for a week, or then given an animal-based diet for a period of time. And you could look here and you could see that within that time period, fiber intake goes up on the plant-based diet, down on the animal-based diet, and the converse for fat intake on the bottom, as you would expect. But the interesting finding was when you looked at microbial diversity here on a scale that means that the higher it up is on the chart, the lower the diversity, in fact, just to confuse things. But on the right, you can see that within a couple of days of going on to an animal diet, the diversity of the microbiome drops. So very rapid shift. So we just need to be mindful of that when we study inflammatory bowel disease. So some of the data that we're getting is consistent. Other data is a little less so. What are the observations that we're making overall? Well, omega-3s seem to reduce the risk. Fiber generally seems to reduce the risk. Increased saturated fats and red meat perhaps increase the risk, particularly of ulcerative colitis, and sweetened beverages probably come along in that category too. And then with Crohn's disease, it's probably the lack of fiber, the lack of omega-3s, and perhaps processed or ultra-processed foods as well. Some of the data comes from animal modeling. Some of the data comes from humans. This is a study looking at high-fat diet in mice, where they looked at mice that were fed a diet in milk-derived saturated fats that was high versus normal. And when they did this with the high-fat diet, they noticed an increase in a host factor, this bile acid, taurocolic acid, and then a change in the microbiome, in particular, a growth of this Bilophila wadsworthia. And then, and only then, if you had a genetic background, the development of colitis. So here it's really interesting. So you could see you need to have the environmental factor, the high-fat diet. You get a shift in the metabolome, that's the bile acid. You've got a microbiome factor that's altered, that's the Bilophila wadsworthia. And then with a genetic background, here it's an IL-10 knockout, you develop colitis. The emulsifier story is very interesting. Emulsifiers are prevalent in a lot of processed foods. And some healthy processed foods. This is mayonnaise on the right without emulsifiers. This is nice-looking mayonnaise with emulsifiers. And the interest here comes really from this beautiful study by Bernard Chassing from Nature from a number of years ago now, where there was a series of very beautiful animal and cellular experiments and some data from man, but in particular where they fed animals concentrations of these two different emulsifiers. This was CMC, carboxymethylcellulose, or P80, polysorbate 80. In fact, in concentrations that the FDA describes as being safe or generally safe for human health, then there was a significant susceptibility to developing colitis. Kevin Whelan and James Lindsay in London, with their team at King's, are doing this ADAPT study to see what happens with emulsifiers in people with Crohn's disease. And this is a resupplementation randomized controlled study. It'll be very interesting to see the results of this. 150 people with Crohn's disease. They then get put onto a standardized diet that is low in emulsifiers. And then mostly with the additional foods or snacks, there's one group that's got emulsifiers in them, another group that doesn't. And then they're then going to look over a 24-week period to see how that impacts on a number of clinical and microbial and metabolomic factors. That will be very interesting to see what happens there indeed. So what about the ultra-processed food story? Well, the big story for IBD came with this publication last year in the British Medical Journal from the PURE study. That's the prospective urban and rural epidemiological study. Now, like many of these studies, this wasn't set up to study Crohn's disease or ulcerative colitis. It was set up to study cardiovascular risk and cancer and the impact of diet. And so we have to just bear that in mind a bit when we start to interpret these data. What did they find? Well, they found in this cohort there were a number of participants who developed Crohn's disease, a number of participants who developed ulcerative colitis, and they saw there was an association with ultra-processed foods and the development of Crohn's disease in particular. When they adjust their model for confounding factors, the association with ulcerative colitis goes away. In Crohn's disease, it remains, but it's definitely going, well, not definitely, but it appears to be going back to the null. So whilst there is a very intriguing association that we need to study in more detail here, they do very clearly note in their conclusion a possibility remains of residual confounding owing to unmeasured or unknown confounders. So we need to really test our assumptions here with these big data sets. And one really important point and plea is that we don't ever start labeling or blaming our patients with Crohn's disease or ulcerative colitis for getting the disease, because it's never the fault of what someone has done. And it's rarely to do with what they themselves have specifically eaten or not eaten over a period of time. Many of my patients who develop inflammatory bowel disease have what we would class as really fantastic diets for their whole lives. So it's a much more nuanced and complex issue than that. Nonetheless, these are important clues that merit further investigation. A similar sort of study, actually, in fact, here is from the Nurses' Health Study. This is from Ashwin and Kristen. And in this study, they looked at dietary fiber, published in Gastroenterology a good number of years ago now. And this showed that higher fiber intake was associated with a lower risk of developing Crohn's disease, but not ulcerative colitis in this study. But again, when they start to adjust for the confounders that are present in the data set to allow them to do that, the association does start to look less robust. And again, similar to the other study, this was not set out to look at IBD in particular. So very interesting clues. There's a lot of biological plausibility here. There's animal model data that starts to fit in with this, but it's not the full answer yet. So just in terms of testing our assumptions, these are two very interesting studies that were published in the Cell Journal this year. The one on the left compared people randomized either to a high fiber diet with lots of good plant-based fibers or a diet high in fermented foods. And in fact, in this study, it was the fermented foods that had the better anti-inflammatory effect and more positive impact on the microbiome than did the fiber diet. So testing our assumptions a lot. And then on the right-hand side, this really fascinating recent study showing that several different types of artificial sweetener that many people take as part of a healthier diet that doesn't contain lots of sugar, but that these artificial sweeteners were associated with significant alterations in the microbiome, including lowered microbial diversity too. Testing all these things through into inflammatory bowel disease ideally then means interventional studies that are quite hard to perform, but nonetheless are important to do so. And we probably need to start thinking in terms of the rigor with which we test pharmaceutical compounds when we're testing dietary strategies. These studies are starting to be done. They're not perfect, but it's great to see that we're getting there. This is the DINE-CD study, large numbers, mostly looking at clinical outputs. And what you saw here was that with a 12-week shift in either a specific carbohydrate-free diet or a Mediterranean-style diet, and looking for outcomes in Crohn's disease, that both these diets affected an improvement in clinical outcomes, but that there was no difference between these two dietary strategies. There's no reference arm here. There's only a proportion who have biomarker data. But nonetheless, I think this is to be commended as really trying to raise the bar with what we're doing with dietary interventional studies. People are demanding these studies, and that's not just patients, it's us clinicians too. So I think it's important to see what we're doing here. Okay, so this is really starting to hone in on what's happening within inflammatory bowel disease, what the environmental impact is. And a number of years ago, I was thinking about how we could study the environmental impact on the development of IBD, and starting to wonder if we were looking already in people who had IBD. If we look at diet and microbiome, there's this problem of causality. But if we look at the impact of diet and the microbiome on events subsequent, then we might be able to get close to this. And indeed, testing the hypothesis that the triggering events for disease flare and the evolution of disease may be similar to those triggering events that lead to the onset of IBD in the first place. So from here, we set up our PREdiCCt study a number of years ago now, looking at what causes disease flares in IBD and really trying to answer some of the questions that patients were asking us in the clinic. What should I eat? How do I stay well? What's the impact of IBD on various psychosocial factors as well? So we've taken 2,500 people recruited in clinical remission and then done a deep dive into the microbiome, calprotectin, looking at environmental and psychosocial factors and as well as diet. Then importantly, with longitudinal follow-up to see over time and then compare those baseline factors in those people that flare over time versus those that do not. Primarily aiming to test which aspects of diet, environment, the genome and the microbiome are associated with and predict disease flare in Crohn's disease and ulcerative colitis. Most of our primary objectives are around diet based on what we knew from the literature a number of years ago: animal protein intake, dietary fiber, N6 polyunsaturated fatty acids, dietary emulsifiers, as well as looking in the microbiome. We've recruited 2,500 people with very standard entry, looking to see whether or not people had well-controlled disease at recruitment, and with a subgroup who will be in deep remission as well with normal biomarkers. When the pandemic hit, we'd recruited 2,600 patients, so that's where we closed recruitment. This is from 49 sites who've done a wonderful job across England, Wales, Scotland, and Northern Ireland. And we're really in the final phases of cleaning the data now to do the analysis. We have 48 months of follow-up in most of these patients. We have a very detailed set of questionnaires at baseline, looking at medications, looking at quality of life, looking at psychosocial variables, anxiety, depression, resilience, sleep, stressful life events, exercise, weight loss, for example, as you can see here. But the main dive is in the diet. Our key dietary variables at baseline come from the Scottish Food Collaborative Food Frequency Questionnaire that looks at 175 commonly eaten types of food, where people are asked to document what they've been eating over the last few months. But we also have a big subgroup with 4-day weighed food diaries with stool samples collected on day 4 for microbiome analysis and comparisons. So I'll be really excited to come back and share these data with you soon. This is all ages from 6 upwards, mix of Crohn's disease and ulcerative colitis, as you see here. It's very interesting that we asked people what they thought caused their flares to happen. Number 1 was stress, number 2 was dietary changes. So we'll be looking into this to see what actually transpires when we followed these people longitudinally over time. Because ideally, we're comparing those people on the left who have no flares. You can see calprotectin's flat, and on the right with a flare after recruitment with the calprotectin rising over time. So bringing this all back together then, where are we with this epidemiological journey, looking at this rapidly shifting environment and trying to make sense of the increasing burden of inflammatory bowel disease across the world now? I want just to share one recent, really fascinating meeting and series of conversations I had. I was in Alexandria in Egypt over the summer at the first Pan-Arab Crohn's and Colitis Association with gastroenterologists from across North Africa and the Gulf, talking about what's happening in the region there, the environmental shifts, as well as this really rapid rise in the incidence and, of course, prevalence of IBD that they're seeing. And this was from Suleiman Hussein, a surgeon in Khartoum in Sudan, who was telling me about his experience of Crohn's disease as well as ulcerative colitis there. Khartoum is a city of 5.5 million people, was one of the fastest growing cities in the world before the war hit the region a few years ago now. They're seeing rapid changes. It's a very urban city already, very Western lifestyles already, and that's changing more. And he's seeing a lot of Crohn's disease and ulcerative colitis coming through now already. These are the places, I think, where we will start to get better and better clues as to what's happening with IBD over time. So thank you for listening. That's a whistle-stop tour through environmental factors in Crohn's disease and ulcerative colitis. And I will be back very soon to think about other factors that are associated with Crohn's disease and ulcerative colitis, looking at the genome, looking at the microbiome, as well as, of course, looking at drug therapies too. So thanks for your attention. I look forward to your comments below. Goodbye.